Hello and welcome to you from wherever you are in America. We are thrilled to have you here with us today. On behalf of the American Cancer Society, the National HPV Vaccination Roundtable, the Indiana Immunization Coalition, I am pleased to welcome you to our fourth quarter Best Practice webinar series. Today's content is focused on system and policy interventions. Earlier webinars focused on patient and provider interventions. All of those recordings are available to you on the HPV Roundtable website. Today's program is also supported by Humana as part of their organizational commitment to lessen health disparities through improving HPV vaccination rates. Thank you, Humana. Next slide. I'm Jennifer Konga with the American Cancer Society's Implementation Science team. Our team proudly leads work with health systems, payers, state coalitions, and other public health partners to improve HPV vaccination rates in practice, thanks to partnership and funding from the CDC. For colleagues who can't attend today's session, this will be recorded, and yes, we will share the slides with everyone. They'll be sent out after today's call. Next slide. We have a robust agenda for this Q4 call. We are bringing you a variety of clinical and public health leaders implementing policy changes at two levels. We'll hear about system-level interventions from the go-getter team at Texas Children's Hospital. We'll also hear about policy interventions, meaning little p policy, organizational practice changes, as opposed to big P legislative policy changes. Throughout the presentations, we invite you to use the Zoom features, pull up that Q&A chat box, and post your questions that you have during the presentations. We will have time for a rapid-fire panel Q&A at the end. And of course, don't leave early, because in the spirit of the holiday and all things thanks and all things happy, there's a lot of free takeaways for you to take and use in practice. And we'll also be asking for your input as we work on planning towards 2025. Next slide. Continuing medical education credits. If you're here and you're seeking to earn some CMEs for today's session, you'll receive an activity evaluation via email from Indiana University School of Medicine. Within 30 to 60 days of this session, learners will get a separate email with instructions on how to obtain your proof of participation. In this gray box on the screen, you have the contact information, so feel free to screen grab that. It'll also be in the slide download with the contact information from the School of Continuing Education. Next slide. So let's get to the real reason for today's call. And on the main stage, we welcome representatives from 3 organizations. Our first cancer prevention team is the dynamite quality improvement powerhouse that is Texas Children's Hospital. 3 years ago, Texas Children's shared on a National HPV Roundtable national meeting the progress that they were making on HPV vaccination. So I'm really excited for them to share their efforts over the last 3 years with this national audience. Starting out from Texas Children's today is Dr. Stanley Spinner, Chief Medical Officer and Vice President of Texas Children's Pediatrics. He's joined by his colleagues, Ms. Rachel Cunningham, who's the Immunization Registry and Education Supervisor, and Dr. Julie Boom, Director of the hospital's immunization project. Welcome. We're then going to travel to the Midwest and hear from the change agent extraordinaire, Ms. Lisa Robertson, the Executive Director of the Indiana Immunization Coalition. And she'll be sharing some of the really interesting policy interventions Indiana has taken. Then we're going to travel back across the country to the Pacific Northwest to my colleague to hear from Shar Ronio, my colleague at ACS, who's also a co-leader of the Washington State HPV-Free Task Force. And she'll be sharing some of the interventions that their task force has led. So please join me in a round of virtual applause to welcome today's cancer prevention leaders. So Dr. Spinner, the floor is yours.
Well, thank you, and thank all of you for attending today. It's a great honor for us to be able to talk with you about the progress that we've been making in HPV vaccine. Uh, the title of our presentation is Texas Children's Hospital Designing a Targeted HPV Vaccine Improvement Plan. First of all, we have no financial or disclosures or conflicts of interest to disclose. Our objectives are to describe Texas Children's Pediatrics, as well as Texas Children's Hospital's efforts to improve HPV vaccine uptake, to discuss our Texas Children's Pediatrics HPV vaccination rates, and talk about the assessment we did with our providers back in 2021, and to explain and assess the impact of HPV educational videos delivered via text message on HPV vaccine initiation among adolescents. So just a quick introduction about Texas Children's Pediatrics. We are part of the Texas Children's Hospital system. We are the primary care arm of the system. We have 66 primary care practices between Houston, Austin, and College Station. We are the largest pediatric primary care group in the United States. And just a quick review of the HPV vaccine timeline. So back in 2006, the vaccine was initially approved. In 2017, the CDC expanded the recommendation down to 9 years of age versus initiating at 11 to 12. Although it was really more of an asterisk at the end of the page, it really wasn't something that people were doing. It was primarily recommended to start at 11 to 12 to be bundled with the adolescent Tdap and meningococcal vaccine. In 2019, as I was looking at data as far as initiation and completion of our HPV vaccination rates for our TCP patients, and especially looking at the HEDIS measure of trying to be completed by age 13, it was very clear that it was hard enough to initiate, but it was even more challenging to get that second dose in. What we were seeing with our data was that we were seeing kids at 9, 10, and even 11-year-olds for their well checks. But when we started looking at data starting at age 12, it was like looking at the back end of a roller coaster. It was just coming straight downhill. These kids just weren't coming back in again for several years. So it was much more difficult to get that second dose in. And so at that time, I reached out to our leadership at Texas Children's Hospital, Dr. Boom, as well as other experts in the field, and said, is there any reason why we can't start offering the vaccine at age 9? And they said, well, no. So what we did was we really worked at it at the system level to go ahead and make this a recommendation to start initiating HPV vaccination at age 9. So what we did was we built that into our EPIC forecaster. We built it into our smart sets, for EPIC, which is our electronic medical record. We did our reminder recalls for families, and we also built that into our standard delegated orders. So it became the expectation that we would start talking about and offering the vaccination at age 9 rather than age 10 and 11. So we would have that time to get that second dose in at age 10 or age 11 when they were still routinely coming into the office. And then for 2022, we went ahead and launched our Send the Right Message project. But in order to do that, we went ahead and started to look out to our physicians really the year before in 2021 to understand what are the barriers for initiating and completing the HPV vaccine. Eventually, the 2030 Healthy People target of getting 80% of all adolescents between the ages of 13 to 15 receiving their HPV vaccine is still that pie in the sky target for all of us. So what we did was, again, we sent out an assessment to all of our physicians in our TCP network and basically asked them, what are the barriers for getting the vaccine initiated and getting it completed? You can see here the various responses. And just one quote from one physician is that, please recognize that a lot of this is outside of the physician's control. I have many parents who are otherwise pro-vaccine, but completely shut down any discussion about HPV. So again, the barrier of parent hesitancy or refusal really was the largest barrier, but getting educational materials out to the families, getting them back in for subsequent doses, those were all certainly additional barriers. And one of the reasons why we initiated the project about sending out educational videos to our families so that, they would have that information before they came into the office. It would send out BMI chart prior to their scheduled well check. And it kind of obviated the need for us to have that lengthy discussion because they already had heard about it in the video. So with that, I'm going to turn it over to Rachel, who's going to take us through some of our data. Rachel?
Thanks, Dr. Spinner. So when we started our project, to sort of set the stage, you can see here some of our TCP data compared to US rates for HPV vaccine initiation. In the light blue dashed line, that is the US rate, the sort of national average based on 2022 CDC NIS data for 13-year-olds. The solid lines are TCP data. And as you can see, TCP consistently outperforms the US rate for HPV initiation. However, when we look at that data more closely, what we noted back in 2021 was that there was a great deal of variety between individual provider rates. We had ranges for an initiation rates ranging from 20 to 90% across our 387 providers in the system. Next slide, please. So what we did, our goal was to simultaneously deliver a strong provider recommendation and HPV vaccine education. We invited all of the providers to create a 1-minute educational HPV video. Providers who chose to participate were given a standard script of less than 200 words. They were able to personalize the script. They could include messages about vaccinating themselves or vaccinating their children. And we filmed these live action videos. You can see a screenshot of one of them here, and we will play one in a minute. But we gave them the option of filming in the clinic or at their home, just whatever their preference was. We then partnered with our IS colleagues to leverage our patient communication platform. As Dr. Spinner mentioned, we use Epic. So we were able to use Well Health, which is the patient communication platform, and identify patients between the ages of 9 to 13 who had a scheduled well child visit with one of the participating providers. We then delivered text messages 1 week ahead of a scheduled well child visit. They received a text message with a brief message stating that they were receiving an important message from their pediatrician and requesting that they watch the video, and it included an embedded YouTube link. We did not widely distribute the videos or make them available. We didn't make them publicly available on YouTube. But then we chose to, after the initiating of the intervention, we evaluated this intervention. Next slide. So we examined the impact of the videos on initiation rates of participating providers, both pre and post intervention. And this timeline is a little confusing, but basically what it demonstrates is that the intervention was rolled out in a staggered nature. So we were able to standardize the pre-intervention period to the 12 months prior to when the provider or groups of provider launch their videos, but we had providers enrolling constantly. We were working towards enrollment. And so we had groups of provider launching at different time points. So for instance, our first provider, our pilot provider, launched in January of 2022, and our last one group of providers launched in March of 2023. And so we looked at the 12 months preceding as the pre-intervention period, and then up until the point of analysis as the post-intervention period. Next slide. So these are the results as of May 2024. I will share more recent results shortly, but we were able to recruit 28 providers across 14 practices and created 17 individual and/or group videos. Providers could choose to do an individual video or a group of providers at one practice. We delivered more than 14,000 messages text messages that generated more than 4,500 YouTube views. Next slide. So this is the video, and if we can go ahead and play it, this is one of our provider videos. And you might want to turn your volume up as well if you're able to, if you can't hear it.
I wanted to let you know that your child is due, or nearly due, for the Human Papillomavirus, or HPV vaccine. HPV is dangerous because it causes changes in our body that can lead to cancer, specifically cancer of the cervix, penis, anus, and throat. These cancers can take years or sometimes decades to develop, but we can prevent most of these cancers now with this important vaccine. We recommend this vaccine in preteens because they actually have a more robust antibody response to fight the virus, even more so than in older teens. The vaccine also works best if it is given before exposure to HPV. This vaccine is safe. Over 120 million doses have been given and is proven to be both safe and effective. I myself have had the vaccine and I plan to give it to my son when he is due. I want you to know that I deeply appreciate the trust that you have in me. I know there's a lot of misinformation out there, and I wanted you to hear this from me. Thank you for your time.
Thank you. Next slide. Thank you. So that was one of our sample videos that she filmed in her home office. So what we did is we evaluated this intervention in a couple of different ways. We adjusted for patient age and provider correlation. And when we did that, looking just at the pre and post intervention period, comparing that for just the providers that participated, not all 387, just those 28 that initially participated as of May. And we found that the impact maintained statistical significance in the 9-year-old age group only. Next slide. So this slide is kind of busy and there's a lot of information, but basically after we conducted that first analysis, we wondered if the providers who were already achieving a high rate of HPV vaccine initiation, if they were impacting the initial results. We wanted to look at it more closely and exclude the providers who, again, because we had such a range in initiation rates in our providers, we wanted to look at what would happen if we excluded providers who were already achieving one of two measures. If they were already achieving the 80% Healthy People 2030 goal, or if they were achieving the national average for HPV initiation of 69%. And so as you can see on the far left graphic, we see that it is notable in the 9-year-old age group. It's kind of hard to see. It looks like the graph got a little bit disfigured, but in the middle one, you can see that odds ratio moves over for 9-year-olds and all ages. And then it just continues to see the most notable impact in the 9-year-old age group and all ages overall when we exclude providers who are already achieving sort of that national average for HPV vaccine uptake. Next slide. Okay, so then we looked at participating providers compared to providers who did not participate. Again, we adjusted for age and provider correlation, and we saw a consistent 5 to 6% increase in each age group. However, these results were not statistically significant. Next slide. We performed, again, the same sensitivity analysis by excluding those providers who, again, were at those national standards. And as you can see, when we were looking at all providers, we did not see an impact in any age group. But as we excluded those high-performing providers, we saw a statistically significant impact. It doesn't come across here. These graphs, I think, got a little disfigured, but we see a small but statistically significant impact. You should see that in the 9-year-olds and in the all ages for the graph on the far right. And again, hopefully in the slides we send out, this will be, I know it looks like it's crossing over that confidence interval of 1, but in the actual graph, it is not. And so it was statistically significant in the all ages overall and 9-year-old age group. Next slide. So where are we today? We have continued to enroll providers, and we are now at 33 providers from 15 practices, and that includes all 3 of our geographic locations, Houston, Austin, and College Station. We have created 19 individual or group videos that have resulted in more than 21,000 text messages being delivered and that have generated more than 8,000 YouTube views. Next slide. So in conclusion, our intervention, it does demonstrate a small but statistically significant impact on those younger ages and all ages overall. And we know that by initiating younger, there's a lot of data that suggests initiating at a younger age leads to improved completion rates. We do plan to follow them out to evaluate whether these children that have been intervened upon, whether it improves the provider HPV uptake and whether they improve their completion rates. It does suggest that overall it may benefit providers who have lower HPV initiation rates, those that are not yet initiating HPV vaccine at a rate consistent with national goals or standards. As you can tell from what Dr. Spinner described, he led a pronged multi-year effort to improve HPV uptake in the institution. And it really, because it is so difficult, any and all interventions that move the needle may be meaningful. And so these findings are modest but promising, just especially given the current context surrounding HPV vaccine uptake. I know that there's a lot of text on this slide, but we wanted to include some feedback from some of our providers. This is anecdotal, of course, but it is important, especially when you're looking at enrolling other providers. That feedback from current providers can be helpful and more compelling than sometimes data. But in general, we've had some really positive impact where some positive feedback where they've said that anticipatory guidance has really made the visit easier. It's streamlined their visits, that it has reduced the amount of time they have spent counseling for those patients who have watched the video. And so overall, the feedback has been really good, and we have not received any negative feedback, which is also a positive. So I think that is it. Thank you so much for listening, and we're happy to answer any questions at the end.
Hi, I'm Lisa Robertson, the Executive Director of the Indiana Immunization Coalition. Next slide. The mission of the coalition is to reduce the spread of vaccine preventable diseases through immunization, education, advocacy, promotion, and collaborative partnerships. And so the coalition does a lot of work across the state and policy, both at a legislative level, but also with our health systems and our State Department of Health, as well as internally. This past year, the coalition's administered over 50,000 vaccines. So we're also in the thick of the vaccination world. So I'm going to talk to you a little bit about a lot of different interventions that Indiana is doing. So next slide. Our first and kind of the most long-lasting intervention that we have been doing is our HPV summits, and this is in partnership with our American Cancer Society in Indiana and also the Indiana Department of Health. Next slide. So the objectives of an HPV summit is that it explains the cancer and what cancers are linked to HPV infection, the burden of disease associated with HPV cancers, and it models effective HPV vaccine recommendations and answers commonly asked questions. So we talk about misinformation, we talk about the questions that parents are asking, and how do providers respond to those as quickly and efficiently as they can. Our focus with our HPV summits is typically on health system engagement and promoting it to their providers within their own health system. So, for instance, we were recently at Fort Wayne, and we were working with a health system up there. So we brought in their local providers. Our speakers at that conference were local to that system. So we had an OBGYN from that health system talking about HPV-related cancers that they see. We had an ENT come in and talk about throat cancers, and these are providers talking to their peers within the same health system. Our summit typically lasts 4 to 5 hours long, and of course, we provide continuing education for all of our summits. Next slide. This is just a typical kind of agenda for what our summits look like, and we will share any of this information and all of our resources with anyone who requests it. But it really is a great way at a systems level to bring in pediatricians and family physicians who don't see the long-term impacts of HPV, so they're not seeing those HPV-related cancers. So bringing in, gyn-oncs and OBGYNs and ENTs from their own system to talk about what their patients look like when they don't have the HPV vaccine has been a really important and powerful part of this program. Next slide. Our second and probably our newest intervention, which I'm really excited about, was Dr. Lindsay Weaver. She is our Indiana State Health Commissioner. We wrote a letter, and she graciously signed the letter and sent it out for us. Next slide. So this is a picture of the letter that Dr. Weaver signed. And basically what the reason for this letter was Indiana as a state has been doing a lot of work around HPV vaccination over the last decade. And actually this year is the first time that our up-to-date rate is above the national average. So that was super exciting considering we were last in 1 year. But one thing that the state did, and we'll share this letter as well, we have a template. You can change out all of the logos and add your own. But as we talked about what the state is doing, so, they think this is important enough that they've changed the registry to forecasted age 9. The state did a reminder recall. They put a lot of effort into policies that they could change on a state level. And then the next part of the letter says, okay, as the chief medical officer of this health system, here are things that you can do at a health systems level to increase HPV vaccination rate. And then she sent this out to all of the chief medical officers of our major health systems in Indiana. We don't have any results from it yet. We just sent it out at the end of August, so it's a fairly new initiative for us. Next slide, please. So another partnership that we did, and this was in partnership with the Indiana Department of Health, was our maintenance of certification project. Next slide. So I won't read this all to you, but maintenance of certification, all providers need it. It's a performance and practice project, and it counts towards the Part 4 piece of a maintenance of certification. Next slide. So our maintenance of certification project, thank you, is really geared towards providers, but anybody can do it. So we've had nurses do this program. We've had office managers do our program. And the goal is it's a 6-month quality improvement project. And we're looking at initiation of HPV vaccination. And we're looking at ages 9 through 21 with the goal of increasing vaccination initiation by 25%. And the cost to participate in our maintenance of certification is $50, which is incredibly inexpensive for maintenance of certification. Next slide. So this is this was the very first year that we did it. We had 36 pediatricians complete our maintenance of certification across 14 different states. 50% of those showed 25% or greater rate of improvement in vaccine over their first 6-month period. Next slide. 61% had some increase, so maybe we didn't reach that 25%, but they did show an increase during their project. Next slide. So what happened after that? So like I already said, we were at the bottom of HPV initiation. We were last in our initiation for boys, and we were pretty abysmal across the board with our HPV vaccination rate in the state of Indiana. So in 2018, the Indiana State Department of Health mandated the maintenance of certification project for any vaccines for children's provider who had an HPV vaccine rate below 25%. And look, you can go ahead to the next slide. So of that, those VFC providers, 553 of them enrolled in the maintenance of certification project. 217 of them completed the program. As you can imagine, the state said, you have to do this. So we had a lot of people enroll, but a lot of them enrolled, but then did nothing, or they just entered zeros. But 217 of them did go through this project. So of those, 38 providers had greater than 25% increase in rates over that 6-month period. 79 of them had an increase. And then we looked at this again in 2022. And of that original list, we went down from the 288 providers to 143 providers that had 25% or less in initiation of HPV, and only 60 of them were repeats from the very first list that the state had. So we did show a lot of change in HPV, at least initiation, and those providers who did engage in the maintenance of certification project. And the other thing that the state did was in 2019, they required any provider who had less than a 50% HPV vaccination rate to do one of their education components of the VFC program had to be around HPV. So if you were a VFC provider, you have to do 2 educational pieces a year. And so the state mandated one of those be HPV related in order for them to re-enroll in VFC the next year. So they have really put a lot of thought and a lot of attention to making sure our HPV rates continue to increase. Next slide. So a few other policy initiatives that the state of Indiana has been working on is the registry now forecasts at age 9. So CHIRP, which is our registry from 9 to 12 years old, shows that HPV is due now. And then 13 or older forecasts as past due. So this is a great reminder for providers when they're in the system that they can start this HPV vaccine at 9. One thing that we learned a couple of years ago was that our school sports physical paperwork does not include or did not include vaccine information on it. So there was no questions about vaccinations on the school sports physical paperwork. So we did about 3 years ago, they willingly changed a few very small pieces on there, but at least ask parents, like, is your child up to date on their vaccines? That reminds providers to look at their vaccination history. So a lot of times kids are going in for sports physicals at, minute clinics and those kind of places. So we thought it was really important that they at least have some reminder about vaccination on their sports physical. We do a legislative breakfast every January. We did an MCE joint partner letter, so Medicaid managed care entities. We co-branded a letter with them and several other partners that went out to all of their providers. And then we also did a parent letter. And so again, just taking all of the different partners that we have who can touch this space and making sure that they're actively engaged. Next slide. So Indiana's hosting, got to throw this in, hosting the National HPV Conference, April 15th through 17th, 2025, and it's downtown Indianapolis. Next slide. We have a great speaker lineup. It's all on our website, which I will put in the Q&A. Next slide. These are the different tracks. So it's anybody in the HPV space. So it's not just vaccination and prevention, but we're also looking at research, public health, cancer screenings and treatments, survivorship. So the whole spectrum of HPV related disease. Next slide. Our college campaign is Project HPV Free, which is just www.projecthpvfree.org. Next slide. Vax Champs is our pharmacy and dental program. So if you have pharmacists or dentists that are interested in vaccinating, these programs are designed specifically for them, and there's continuing education. They're all online video modules. Next slide. And then the 2 new things that we're working on right now is the dental HPV information brochure. In Indiana, dentists can now vaccinate, but they're not. So we're working on those barriers. And we're also looking at postcards for parents of 8-year-olds to kind of give them a heads up that they're going to be offered the HPV vaccine when they come in for their 9-year-old checkup, and what that, why that's important, because we've been saying for so long, like, oh, you won't need another vaccine until you're 11 or until you start 6th grade. And so they are surprised when we offer the HPV vaccine at the 9-year-old visit. So we're looking at doing some kind of education prior to that visit. Next slide. And thank you. And there is my email. So please feel free to reach out to me with any questions or requests of resources.
Hi, I am taking over. I'm Sharonio. I am, as mentioned, sorry, I'm losing some of my screens. I'm with ACS, and I'm the state partnerships and work within Washington and Oregon states. But for this presentation, I'm going to focus on our best practices for the Washington HPV Free Task Force. Next slide, please. The work in the HPV vaccine in Washington is supported by a very active and diverse grassroots, and I will highlight the grassroots component of a volunteer leadership group, which is called Washington HPV Free Task Force. The task force regrouped during the pandemic and has been working feverishly in Washington state since. Next slide, please. But I want to give a little background first that helped kind of pave the way for the work that was done in HPV vaccinations at age 9 in Washington state. In 2021, a small group of 5 came together to launch a short pilot project focusing on beginning HPV vaccinations at age 9, which was later published. The group was comprised of a representative from our Department of Health, myself from ACS, a pediatric physician champion, and the University of Washington Public Health. The team met with 2 different clinics to launch the pilot project around HPV at 9. There was a single pediatric clinic and a pediatric group with 8 different clinics participating. The group met with each clinic individually once a month for 5 months, focusing on HPV education as cancer prevention, the importance of strong recommendations by all staff and not just providers, how to clean vaccine data and run recall reminders, along with providing education materials to the clinics. At the 1-year mark, you'll see the first clinic showed a 17.6% increase in their HPV vaccination at 9, and the second clinic had a 33% initiation with a 2% completion rate. And just as a side note, we had a 3-year check-in with that larger 8-clinic group, pediatric group, and their vaccination rate right now is standing at 42% vaccination rates for 9-year-olds, with equal rates of both boys and girls. Initially, girls were higher. Next slide, please. At the completion of the pilot project, the project was folded into the Washington HPV Free Task Force. The task force leadership quickly identified some barriers that were causing difficulties in implementing HPV across the state at age 9. They were the lack of awareness by providers around beginning vaccinations at 9, why they do that. Providers were, we heard, were concerned that there was a contradiction between starting it at 9 and what CDC says, which isn't true. There was confusion because our Washington Immunization Information System forecast showed that HPV at 9 was optional, but that it wasn't due at that time. Other things that also were found to be barriers is that 9 to 10 coverage rates weren't being tracked at a state level, as well as there was inability for systems to change their EMR prompts to identify that vaccinations were due. Next slide, please. So providers relayed also to us that when we discussed with them that when they were in their appointments, they were very busy. They were trying to accomplish a lot. They often didn't initiate the HPV vaccination at 9 because when they viewed the IIS system, it showed that vaccines at 9 were optional. And they reported that because they were so busy, they only focused on those that were needed that day and were due. So, seeing this as a barrier, the HPV task force requested a meeting with the Washington State Vaccine Advisory Committee to discuss changing the Washington IAS forecast to show due at 9 for HPV vaccination, opposed to listing it as optional. Next slide, please. So July of 2022, the task force was granted a meeting with the vaccine committee. The task force put together presenters from Washington Department of Health in office immunization, clinical quality assurance, and DOH, Deputy Director of Health Promotion and Education. We also had a representative from the Washington HPV Task Force and had our task force pediatric physician champion present. The presentation focus, similar to what was talked about before, was addressing healthy people 2030 goals, the impact that the state was having from the impact and vaccination rates, and that the state was still working just to catch up to the loss that we had during the pandemic. It was identified that the state was falling short of completing HPV vaccination series by the children's 13th birthday. Presentation also highlighted emerging best practices for beginning HPV vaccination at age 9, along with providing supporting journal publications outlining at 9 successes, as well as we included the outcomes from the local pilot project that we completed. The organizations that endorse beginning at 9 vaccinations were also highlighted, which are shown on the slide, as well as the committee was provided with letters of support for changing the IAS. Next slide, please. The task force asked the vaccine committee for 3 different motion requests to encourage providers to routinely start HPV vaccination at 9, to change the Washington IAS forecast to begin HPV vaccination at 9, so changing to do opposed to listing it as optional, and to track vaccination rates for 9 to 10-year-olds at a state level. We were excited that the committee passed all 3 motion requests unanimously and forwarded the recommendation on to our Washington Secretary of Health, Dr. Shaw. Dr. Shaw agreed with the committee's recommendation and began the process to change our state's IAS. Next slide, please. Process took about 6 months to make the change, but on January 20th, 2023, the immunization information system was changed to show forecasting for HPV starting at age 9. Prior to the change, the Washington DOT sent out statewide vaccine provider letters from our state immunologists, notifying of the upcoming change and providing justification for the change. When the forecasting then was enacted in January, a second letter was sent out notifying providers of the state's change. Next slide, please. To support the IAS changes, the Washington HPV Free Task Force also sent a Dear Vaccine Provider letter notifying of the recent change. The task force also developed a Why at 9 webinar that helped educate providers and clinic staff around beginning vaccination at 9, and that was held on the DOH website for 6 months, so individuals could go back in and grab that for education. Another very exciting piece that we feel is that the Department of Health developed a separate page on their website called HPV at 9. The page houses resources, data links, materials around HPV in multiple languages. And I believe right now we sit at 12 different languages to date. There are also trainings available, social media posts available, and other @9 resources are highlighted. All of it is housed in a very simple, easy to access location for providers and anybody that's interested in vaccinating at age 9. Next slide, please. The HPV task force also provided materials that we sent out to clinics, cited here. Next slide, please. And the exciting piece is to show the growth that we have had in the short period of time since our IS was changed. We've had in a year and a half a 6.3% increase, and the state has also started tracking HPV rates at 9 to 10 at the state level. And we're looking to do that for boys and girls and also ethnicities. Very excited about having that data information. And just as a note, our August back to school month, the state provided over 5,000 HPV vaccinations to 9 and 10-year-olds in just the month of August alone. We're excited about the growth that is going on in Washington and excited to see what we hold coming in the next year, and appreciate the opportunity to present to everyone.
Thanks, Shar. Very exciting progress in Washington. Love to hear it. Let's bring all of our panelists here and live into the Cyber chat room. We've got lots of audience questions. So much great information on interventions at the system and policy level. And in the spirit again of what we're taking away for the holidays, I just want to high level some of the things I heard about interventions. So from Texas, we heard about epic forecasting and smart sets at age 9. We heard about personalized provider videos with invitational text messages. And we heard about teaming with the information system to build that data report for your well child visits. And then Indiana shared interventions about the stakeholder summit, the letter to all the chief medical officers, and the maintenance of certification. And now Shar just shared with us additional interventions for the IIS in Washington setting at age 9, and then the follow-up kind of educating the provider core of the state on those changes. So I'd like to invite, oh, how cute are we? We're tiny little chairs all together in the virtual conference room, our mini me selves. I'd love to first ask the panel before we turn to the great questions in the chat box. What are the lessons learned in your Twitter version that you want to share with the audience as they take away, they leave with the intervention knowledge you shared, but what would be the tips and tricks that you'd share with them? Texas team, let's go to you first.
I would say know your audience. And briefly, our local pediatricians didn't want to be told what the problem was. They knew what the problem was, and they needed help fixing the problem.
Thanks, Dr. Boom. Indiana or Washington, what advice would you share?
In Indiana, I would say working hard to build and sustain partnerships so that you can all work together on similar policy goals. And also, it's best if we can provide a template for everything. So we write letters for everyone. We make it as easy as possible for health systems, our health commissioner, our MCEs to just add their logo, sign their name, and send it out. So the easier, the better.
And I would echo what Texas said. I think having the opportunity to talk with providers and actually find what they're saying is the sticking points for them. And then that's where we're able to take what they were telling us, and how we as a group then went back to try and help fix it for the providers, because they weren't going to be able to fix it. But really listening to what the barriers were, opposed to us just going in and telling them what the barriers were. We listened to them and then took action from there.
Thanks, Shar. We have questions specific about kind of how you work this in terms of technology and digital support for the Texas project. So first of all, maybe Dr. Spinner, you could address a little bit. There's a question about what exactly, you mentioned something about well health. Could you explain that a little more and maybe speak a little bit to the kind of level of effort it takes to put that forecasting and smart sets in place for age 9?
Sure. So in order to make changes to our forecaster, which is really a third-party vendor, but our smart sets across the system can be a daunting process. So the first thing was to get support across the system from all of leadership. Once doing that, I was able to go to our folks who can then bring it to the committees that were responsible for making those changes, knowing that they had support across the system. Sometimes that's not the case. There's some competing forces that sometimes want to do one thing versus another, but all came together to say, yes, this is a good idea and we're all in favor of it. So then it really became a matter of just getting the right people together and the time it took. So not as daunting of a task as other situations that we may face. Talking about well care, it's what we do is we have for our MyChart messages, they are as they are sent out prior to specific well checks, and so these messages were being sent out prior to the the 9, 10, 11-year-old well check, so forth, where HPV vaccine, if it hadn't already been given, would normally be talked about and offered. So that's how we were able to build that into MyChart. So it was automatic. We didn't have to have the providers or anyone in the office pushing it out. It was automatically built into to when a well check appointment was made at the various ages where HPV vaccine should be given, that message would then be sent out prior to the visit.
And some more video questions. Did you have a PR or marketing firm that filmed these videos for your staff?
I can take that. So our original idea stemmed from the thought to make it much like a TikTok video, make it short, relatively informal, really to get at the heart of what the pediatrician felt, was the important parts of HPV. Our first one we did with a vlogger kit hooked up to an iPhone. We wanted to keep it low cost. And so ACS actually helped us get a little $100, $75 vlogger kit. And then as we did it a little bit more, we did find a videographer in town who was willing to do them for the very low rate of a couple of $100 each. With time, we kind of narrowed it down to a 1-minute, what we call a standardized script that we give the provider. They're welcome to edit it in any way they want, but we do keep it to 1 minute because people don't have a longer attention span than that. But we really do try to get folks to say something personal to them, like, I vaccinated my own children, or my mother had cervical cancer. This is very important to me. I want you to hear my message, something like that. And then we video whatever it is. We have used a teleprompter, and when we were going low tech, we were even using an iPad behind the camera as a teleprompter. There's teleprompter apps. So there's way to go low tech, there's way to go a little bit more. But either way, they're hearing the provider of their child talk to them about the importance of HPV and really build on the importance of the provider message.
Thanks so much for that. Rachel, let me ask you a follow-up. In your summary slide, there's a question around the statement of how it benefited providers with the lowest initiation rates. Can you speak a little more to what that means? And then how did you engage providers who were hesitant or said, I'm not making a video?
Right. So we had a really hard time getting the project off the ground. We've had probably the greatest growth since mid 2023, but our pilot provider was willing to participate. And once we got him started and had his anecdotal feedback, it kind of snowballed after that. And we were able to use, that's why I shared the provider anecdotal feedback, because I think the provider to provider persuasion is more effective. And so the numbers can speak, for themselves as well. But but really the provider, once we had a provider from like a practice who participated, it was easier to go back and persuade other providers from that same practice to participate, because they'd seen and heard the experience. We make it really easy for them. We're real, like Dr. Boone mentioned, we're in and out in like 30 minutes. We have a teleprompter. They don't have to memorize anything. We've already written the script. All they have to do is give us 30 minutes and we come to them and film it, and then we're gone and we do the rest. It's really straightforward. And so making it as easy as possible, I think, also helps on top of the sort of provider persuasion. But going to the benefiting so when we looked at that, did that sensitivity analysis, that was when we saw that when we excluded the providers who are really performing at a higher rate, because we offered enrollment to everybody, we didn't base it on what their initiation rate was. We were just willing to accept every provider who wanted to do it. Obviously, that's kind of biases your sample, because those providers who are already more motivated to have those conversations, or maybe are more effective at having those conversations, they're probably just inherent provider characteristics that are biasing that, which we tried to adjust for in our analysis. But when we excluded the providers who already had, because we did have some providers who had like really high rates, when we excluded them and looked just at the ones that were under sort of what we would expect to see, like even in the running for the national rate for uptake, that was when we saw the greatest impact in those lower age groups. Hopefully that answers the question.
In fact, we have more questions than we're going to have time for.
Okay.
And I need to ask one question in Washington and Indiana. There's a couple other questions in the chat, Rachel, that maybe like between the Q&A and the chat, if we don't get to them, including, can we share the link to that video that you shared with the audience? If so, could you somebody drop that in the chat? There's a question about Indiana. Are you tracking at all, Lisa, like the open rates for those CMO letters? And is the coalition or is the state going to do any follow-up? Do you know?
Well, yes, I know they're tracking that, and we're hopefully going to send the letter out again, and then maybe also our letter that the MCEs did to sent out to their providers and parents. We've been tracking that as well. Yeah, we're in a strange spot with the election, and not sure if our state health commissioner will still be here much longer. So we're kind of waiting. We'd like to do some follow-up, but until we kind of know what that landscape looks like, we're at a pause.
Thank you for that. And Shar, the impressive progress that you've made as a state with both the registry and then educating providers in the state, has your task group thought at all about that next step of asking health systems, okay, the registry set, we need to make sure that you're setting your EMR like Texas did to activate at age 9. Is that something else that the task force is looking at?
It is. We continually try and work on those EMR systems. Problem is not all systems are housed here. They're a hospital of another larger conglomerate, which is across states. So we run into issues on making EMR systems. There are some workarounds that have come up on how to do some workarounds if you can't get your EMR system changed. That's huge. I will also say the other component that we also work on heavily is to educate every person in the clinic that works in the clinic about HPV and the importance. How important that person at the front desk is to know about what that is, because you don't want to set mistrust or questions to parents as they're first calling in. The MA's extra. We have had a lot of conversations about how we can support the clinics with their EMR system. So if the MA is rounding someone, they can see, oh, you are up for a vaccination today for HPV at 9.
Thank you, Shar. In fact, we have some resources to share. I think that would be good. And I know we're at top of the hour, so I'm going to ask that we're going to zip through the next things real quick. Thank you, panelists. Thank you for sharing your work, sharing it, and letting us showcase it to a national audience. We're so appreciative. We're going to run through these takeaway resources, and we're going to ask you to do evaluation of the session. Next slide. We got to zip through these, Hannah. So there, if you could grab your phone and scan this code. So after this call, you can tell us what your takeaways are from this and the value of this session. We would be most appreciative. And I think we're probably, for time, Hannah, going to have to maybe skip the next. Oh, I don't know. We've still got folks, but we're losing them very quick. We're going to send you, we're going to figure out a way to poll you. We want to know what topics you want to hear about in 2025. We're starting that planning. Yeah, if somebody can drop the link to that survey in the chat, that would be great. Oh, and I guess we are launching this live poll. So this poll is what we're looking for going forward into 2025. And we are also looking at doing a quality improvement project for systems on adolescent immunization that would involve probably bi-monthly calls and data sharing with ACS. If you'd like to learn more about that, feel free to answer that poll. Let's run through what we've got, Hannah. Next slide. Takeaway resources. The Roundtable has brand new updated evidence summaries. These are snack food size, 2 to 3 pagers to share with clinicians and staff teams around the latest and greatest evidence. What's known, what's new, and what's to come. All of them have that similar formatting, so you can look at all these different topics, accessible on the Roundtable website. These are the gift that you should give every clinical team member and member of your coalition. The best-in-class HPV Vaccination Roundtable action guides. These have been updated to include the age 9 recommendation since they were first launched in 2018, just updated in the last 2 months. Thank you, Christina Turpin, for your leadership on that, as well as the new guide for health plans. So please make sure you grab these. And there is that one for clinical teams, office teams, large health systems, small health systems, nurses, MDs, you name it. There's a guide for it. Next slide. So there's a couple learning events. If you work in rural communities, there is an event on December 4th that you can join us for. And I think they're going to put the link to that in the chat. And then we also have another event for pharmacists. This is Texas specific, but it is open to pharmacists from other states. It's a 2-part series starting tomorrow, looking at the role of pharmacists as vaccinators and HPV cancer preventers. So you can grab that screenshot. Please go home and ask Santa to let your care team attend the National HPV conference that Lisa told you about, and the registration link will be in the slides. Next. Thank you to all of these amazing partners for working together with us in 2024, and Humana for sponsoring today's session. Thank you, thank you, thank you. And again, you'll be getting information if you're seeking continuing medical education. You can contact info on this slide. And I just want to close with a huge, huge thank you to the ACS staff team, who has been so amazing in running this best practice series all year. The HPV Roundtable teammates, Gabby Darville-Sanders and Christina Turpin, Kiera Long, and then our team here on the ACS implementation science side, Kayla Montsalidze, Ashley Locke, Hannah Nine, Katie Crawford, and our dearly moved on colleague, Melissa Santiago. So thank you. Thank you for everything you do to protect patients from cancer. We see you. We appreciate you. Have a blessed Thanksgiving with your loved ones. Thank you for joining today.